This week on the Backtable Podcast.
We all can get better. We can. At the point where you are saying, I'm the world's authority on this, I'm perfect, it is time to get out. That's when you're really going to run into trouble. And so I think the idea of just being open to things, to just continuously try to improve, both for yourself, but most importantly for our patients, is I think it's applicable, again, to this technology. I think it's applicable to technologies that probably go throughout all surgical and medical fields.
Hello, everyone, and welcome to the Backtable ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. Did you know that up to 22% of thyroid surgeries inadvertently result in the removal of parathyroid tissue? This can lead to temporary and permanent hypocalcemia as well as permanent hypoparathyroidism in up to 15% of cases from total thyroidectomies. Hypoparathyroidism is a life-altering condition impacting patients' long-term quality of life. Patients face up to 4 times greater risk of kidney stones, over 3 times the risk of renal insufficiency, and they commonly experience cardiac and neurocognitive complications. The quality of life may deteriorate with impacts on the ability to work, exercise, sleep, and maintain family relationships. Medtronic's PTeye parathyroid detection system is an intraoperative, probe-based autofluorescence technology. PTeye aids surgeons in confirming visually suspected parathyroid tissue during surgery, helping reduce the risk of accidental removal and protecting their patients' quality of life. Remember, seeing isn't always enough. Visit MedtronicENT.com today and discover how PTeye can help you protect with confidence your patient's healthy parathyroid tissue and safeguard their quality of life. Now, back to the show. Hello, everybody, and welcome to the Backtable ENT Podcast. My name is Gopi Shah. I'm a pediatric ENT, and I'm here today with my partner, co-host, and dear friend, Dr. Ashley Agan. How are you today, Ash?
Hey, Gopi. Good morning. I'm loving your new setup in your studio. You're looking so good.
Thank you. There's a lot of light.
Yes.
That helps really smoothen everything out. I'm like, who needs skincare? We just add a lot of bright light. We'll soften it up a little bit.
You look like a movie star. You got it going on.
I don't know if I feel like one, but thank you.
And our guest today is Dr. Michael Singer. He's an otolaryngologist practicing at Henry Ford Health in Michigan, and he specializes in minimally invasive parathyroid and thyroid surgery. He's here today to talk to us about identifying parathyroid tissue during surgery. Welcome to the show, Michael.
Thank you. Pleasure to be with you guys. I'm wondering where my back table swag is. I'm a little disappointed.
Can we say in the mail?
Yeah, please.
All right.
Pleasure to be with you guys.
And so before we get started, tell us a little bit more about yourself and your practice.
Yeah, so I trained in ENT, just residency-wise, and then when I was done, I actually chose to do a fellowship with David Terrace, who he was a head and neck surgeon, then transitioned to only doing endocrine surgery at Medical College of Georgia. And Dr. Terrace is innovative in a lot of ways, but one of the things that he did was he essentially brought minimally invasive and endoscopic-assisted thyroid and parathyroid surgery to the United States. And so I went and did a fellowship with him. I actually ended up staying 2 years because I found what he was doing so cutting edge and really just incredible. After being there for 2 years, my wife and I, we were from the East Coast originally, but we ended up moving to Michigan, have been here since. My practice, and has been since the time I came out of fellowship, restricted just to thyroid and parathyroid surgery. That has been like the goal since the time I started my fellowship. That's really what I'm interested in. I know that might be offensive to some of your listeners, but it's what I enjoy, and it has allowed me to create a volume where I think I'm able to offer patients really specialized, high-level endocrine surgery care.
Yeah. So today we're going to talk about identifying the parathyroid gland during, quote, surgery. Michael, can you kind of set the stage for us? I know when we talked about this ahead of time, it was great to kind of hear how you understood, hey, these are different. We have to think about it a little bit differently when it's specific to thyroid surgery or when we're identifying specific to parathyroid surgery. So can you kind of set the stage of sort of how you think about identifying parathyroid glands when it comes to the purpose or the reason or the type of surgery that you're doing?
Through the research that I do, and my research is mostly on kind of technology and how it can be applied in these kind of surgeries and improve outcomes. But I think this is really important to essentially kind of democratize the surgeries. What I mean by that is that, and I think, both of you are probably familiar with these new technologies, new techniques that are developed, but essentially can only be utilized by all but the most highly specialized expert surgeons. And really what my interest is trying to develop, again, either technologies, techniques, or a combination of the two that allow the kind of quote unquote average surgeon who doesn't do as much just to become better at it, because that's how you impact most number of patients, right? If you only have a technique that's incredible, but can only help 5 surgeons in the world, the impact of that is pretty limited. Here, or at least my goal, is to try and work on things that, quote unquote, again, the average surgeon can adopt relatively easily into their practice. And then the number of patients that you are ultimately benefiting is much greater. And so with thyroid and parathyroid surgery, so anyone who's done those kind of surgeries know that sometimes identifying parathyroid glands can be extraordinarily challenging. One of the things that's interesting to me in this area, though, is that even people who do a fair bit of this, and say certainly some of the companies that work in technologies in this area, they think of parathyroid glands as an organ and that they're kind of the identical issue, regardless of whether you're talking about thyroid or parathyroid surgery. And in fact, the way I think about it is very different. And what I mean by that is the challenges with these glands, even though, again, you're talking about the same exact glands, the challenges in the glands are almost diametrically opposite, right? So in thyroid surgery, yeah, you're trying to find these glands, but ultimately what you're trying to do is leave them behind and be functionally intact from a vascular perspective. And that's almost the exact opposite of the challenge that we have in parathyroid surgery, where really what you're trying to do is find a gland and remove glands, right? And so when you think about these surgeries, even though you're talking about parathyroid glands, the challenges that you encounter in them or you're trying to address in them is in fact almost the opposite of each other. And so both in terms of the surgeries, the post-operative care, the goals with these glands, they're very different, even though you're just talking about the same organ.
Yeah. And I appreciate that you bring up the point that not everyone has access to the super specialized surgeon like you who literally is doing thyroid and parathyroid surgery day in, day out. Being able to have the quote average although we know nobody wants to be called average, but the people that who are still doing all kinds of surgery, and any tool that you could add to make that better, more accurate, more efficient, easier to do that case is huge, right?
I just would say, Ashley, this is actually a really important point, at least from my perspective. I don't mean average in any way in a derogatory way.
I know.
Teasing. I know, but it's really not meant that way. It's that the reality is, let alone outside of the United States, but even within the United States, right? That most people, their access is not to super subspecialists. It's to people who are at, a little bit of kind of the more, community level, and they do it and they're good at it, but they don't do as much. And let's be honest, all of us, what we do, and I tell this to my residents all the time, what we do is really hard. It is. Surgery is really hard. And so if there is any tool that we can use to make it easier, and that's including for me, I'm talking about at the super high end, but even at a lower level, we can do something that makes it a little bit easier for us, great. I'm all for it.
I think that's a great point with that whole access issue. I mean, I think the three of us live in places where there's larger centers, but like if you don't, or if you're a couple hours out, whether it's for yourself or a family member, having to choose whether you're going to get your care, which requires pre-op visits, post-op visits, OR visits, multiple, if it's a chronic health issue, having to drive a couple hours to and from is a big deal. So access is, I think, the key when it comes to that is is part of this discussion as well when it comes to that point. But Michael, can you tell us the difference? What's the difference between hypoparathyroidism and hypocalcemia?
Yeah, so it's an interesting point, because I think when you look at the research related to thyroid and parathyroid surgery, when it's related to parathyroid glands, it becomes extraordinarily complex and confusing. And there's a number of reasons why. One is, we have redundancy of these glands, right? So I try and explain that to patients all the time. This is very different where your thyroid, where it's like you got one and you got one only. Right here, you take out 3 of them, and as long as you have a single gland working, that's all you need, right? So 1 is redundancy. 2 is the way we define these things in the literature is, to say inconsistent is a massive understatement. And people confuse these things, and they use them interchangeably when in fact they're really not interchangeable, right? So, for example, after parathyroid surgery, it's very common for patients to have hypocalcemic type symptoms. Things like tingling, numbness, cramping, the things that we're all taught as a resident are signs of hypocalcemia. But what's interesting is if you check those patients' lab after successful parathyroid surgery, say you've done a single gland parathyroidectomy, they're not hypoparathyroid and they're not hypocalcemic. It's just that their muscle has adjusted to living at a very high level, and all of a sudden it's normal, and their muscles essentially become hyperreactive for a while until their body realizes it's at its normal state. Again, so those patients, a lot of times you'll see in the literature people talking about hypoparathyroidism or hypocalcemia. Those patients are neither of those, right? And so I think the terms just have to be used, especially when you're talking about research. You have to talk about them in very kind of exact and very clearly defined manner.
And moving forward with the conversation, we're focusing on finding parathyroids, whether that be during a thyroid surgery or if you're looking for a parathyroid adenoma or something like that. Before we get to the surgical part, can we touch a little bit on kind of as you're seeing patients and workup preoperatively that helps you? Like, so for example, what kind of imaging do you like to kind of prepare you for surgery?
Yeah, so I'm going to keep hammering on this throughout probably this conversation, and I apologize in advance if that becomes annoying.
Hammer it.
To one or both of you. Really, we have to talk about what surgery are we talking about, right? So in thyroid surgery, patient comes to me, they've got a big goiter, they've got cancer, whatever else it is, right? There's no consideration in my mind of getting localizing studies in those patients. That's not the goal of the surgery. Now, that being said, I will tell you that on all my thyroid patients, I still check PTH levels. I still look for hypercalcemia because it's not unusual for those patients to have concurrent primary hyperparathyroidism. So I actually routinely check those labs on all my thyroid patients looking for parathyroid disease. Now that includes surgical parathyroid disease, and what I mean by that is primary, or say some forms of secondary that can be reversed prior to the surgery, say vitamin D deficiency. Okay. So in thyroid surgery, I'm not thinking about localizing glands preoperatively. Now that's very different, obviously, than in parathyroid surgery, where there really has become an emphasis, at least in my mind, sometimes excessive, on people trying to focus on the idea of which gland is it and can I kind of predict that before the surgery. In patients with primary hyperparathyroidism, in my practice, the one always absolute study that I'm getting is ultrasound. And that's for 2 reasons. First of all, I think particularly when it's surgeon performed, ultrasound is extraordinarily sensitive for finding adenomas, but particularly smaller adenomas, ones that you won't necessarily see on whether it's a 4D CT or say sestamibi or nuclear medicine imaging. But the other thing that I think is critical in parathyroid patients in terms of getting ultrasound is you also want to be looking for, now this is the opposite of what I said before, you want to be looking for concurrent thyroid disease. In my practice, about 5% of the patients that I operate on, I end up doing both surgeries. That's how common these diseases are to run together. So people argue a lot about what's the best imaging study for parathyroid disease. And, you'll see endless, at least in my mind, endless papers on what's the best study to get. Well, first of all, I tell people it's institutional, right? Like, we all practice in different settings, different places. There are places where patients come from, where they come with sestamibi scans to see me, and I'm like, okay, I don't even need to look at it. It's going to be negative, right? I just know that they don't do sestamibi scans frequently enough that it's going to be a positive result, right? And at other institutions, 4DCT is amazing, and other places, sestamibi is great, whatever it is. So I don't think there's an absolute. I know that in my practice, ultrasound is extremely sensitive for parathyroid localization, but again, I think it's important to recognize it's also looking for concurrent thyroid disease.
Can you expand a little bit? So for the patients that come in for what you're working at, for example, a parathyroid adenoma, and you do an ultrasound, you're also looking at the thyroid gland. What kinds of thyroid problems are you seeing? Is it just like single nodules that then you have to get FNAs for? And then vice versa, the patients that come in for a thyroid problem that you're drawing labs on, you're like, oh, the PTH is high. What kind of concurrent pathology or, diagnosis are you also seeing?
Yeah, so we'll start with, just to kind of keep it consistent with my prior comment. So just thyroid surgery. So certainly the most common thing that I see is secondary, particularly where I am in Michigan. Vitamin D deficiency is insanely common. And so I think it's helpful in all patients to kind of replete that. But in my mind, there's really two primary reasons. Okay. And this goes back to your question from before about hypoparathyroidism versus hypocalcemia. I think that in patients who have total thyroidectomy and are at genuine risk of hypoparathyroidism, the question with the hypoparathyroidism is, do they become symptomatic and actually put at risk, right? We all know about tetany and, oh my God, are they going to show up and they're not going to be able to breathe? That's not from the hypoparathyroidism. That's from the hypocalcemia. And ultimately, and this is, studies have shown this consistently, that the patients who do become hypoparathyroid, the ones who are more at risk of becoming hypocalcemic and consequently then symptomatic are those patients who are vitamin D deficient, right? So those patients, if you can replete them beforehand, there's some studies out there that suggest somehow that repleting it reduces the risk of hypoparathyroidism. I don't believe that's true. I'm not sure how that would possibly work from a surgical perspective. I mean, if you devascularize the glands, if you traumatize the glands, they don't care whether the vitamin D is high or low. But what I do think is that those patients are in fact more at risk of developing hypocalcemia as a result of the hypoparathyroidism and then becoming symptomatic. So those patients I replete for that reason. The other reason, even when I'm doing hemithyroidectomies, this may sound strange to people, but even when I'm doing hemithyroidectomies, I like to know that level beforehand, because if they have vitamin D deficiency, it's not unusual to get in there and find, guess what, enlarged parathyroid glands. And you don't want to be in a situation where you go in there and you say, oh, look, I found enlarged parathyroid glands. The patient must have parathyroid disease too. I'm going to take these out. So to some extent, it's repleting the vitamin D. To some extent, it's recognizing what you're actually dealing with. But it is not unusual, patients, particularly patients with mild hypercalcemia, where I'll see patients who've been walking around for years with mild hypercalcemia and no one's ever said, hey, do you know that your calcium levels are a little elevated? And, I'll then check a concurrent PTH level, and those patients have primary disease. And so in my mind, if I'm going to be going to the operating room and someone needs to have both, you want to know that at the time you're there. You don't want to be like, oh, wait, I wish I had checked this beforehand. Now I don't know what to do. And to some extent, that's the same on the parathyroid surgery side of things. And what I mean by that is, historically, the way parathyroid surgery was done, certainly in the age before all these imaging studies were performed, was patients were brought to the operating room, and the standard, because there was no information beforehand, was bilateral neck exploration. There was no preoperative localization that was obtained. And so because of that, routinely, patients would be brought to the operating room, and in addition to finding maybe a parathyroid adenoma or parathyroid hyperplasia, people would find, oh, wait, here's a nodule. Okay, so what is this? Is this malignant or not? Should I take this out? So then you would see all these frozen sections being done. And then a patient maybe would end up with a hemithyroidectomy. And the reality is, just like everything else, like we want to go in with as much of a plan as possible, right? And so when you say like, what thyroid disease am I finding? Certainly the most common is thyroid nodule disease. And oftentimes that's single disease, but sometimes it's multinodular disease, but certainly single nodule disease. And then in those patients, I go down the same pathway I would if they were presenting to me with a single thyroid nodule. Is this something that warrants biopsy? Is this something that should be at a minimum discussed with the patients? Because sometimes I mention it to patients and they're like, I don't want to know about it. And that's not why I came here. I came here to have parathyroid surgery. Why are you talking to me about thyroid? That's fine. But I don't want to ever say to a patient, oh, don't even think about it. Meanwhile, they have a thyroid cancer that I could have easily addressed at the same time. So in both cases, there are things that are just trying to give me as much information as possible before I go to the OR to know what I'm actually dealing with in a patient.
Yeah, that makes a lot of sense. For your labs then, so you've got vitamin D, PTH, you're doing ionized calcium or just total calcium?
We use, at my institution, I use ionized calcium in my thyroid patients, right? So I'm getting a basic metabolic panel. So I have a serum calcium level. I get ionized calcium levels. I get a PTH and, like you said, a vitamin D level. It's interesting because with calcium, you have patients who are walking around and their serum calcium levels are they're in the normal range. They're probably at the high end of the normal range, but because they're not above the high end of the normal range into abnormal, right? Like the EMR doesn't flag it. But then you'll check an ionized calcium level and that number will be elevated. And in those patients have hypercalcemia and oftentimes have concurrent primary hyperparathyroidism. So I actually am checking both in those patients.
And a TSH?
So it's funny that you say that. So in most patients who come to see me, certainly for thyroid disease, already have that. But what's amazing is not all. But then, yeah, in my parathyroid patients, I do check a TSH level because there's patients who are walking around with either hyperthyroidism or subclinical hyperthyroidism. And again, it's just about knowing that beforehand. You just want, if like I'm going to be bringing a patient to the operating room and they need an intervention on both thyroid, parathyroid, I want to know that. I don't like afterwards saying to a patient, oh, I wish we had thought of that beforehand. That is far from ideal.
Yeah. Any other labs? Does that mostly cover it?
Basic labs for patients.
Gotcha.
So in terms of like, and again, I want to continue to clarify the two types, like, so for thyroid surgery and then separately for parathyroid surgery, what is the transient risk of, and maybe it depends on if I'm doing a total thyroid or hemi or, if it's an adenoma, but how do you counsel patients when it comes to the risk of hypothyroid? And then part two, which again, maybe there's a lot just in the first question, but do you have to identify all four or are you like, oh, this looks like it's it, or hey, there's the adenoma, that's it, or, how do you kind of think about that as well?
So let's focus on, in terms of hypoparathyroidism, let's focus on thyroid surgery first, right? So at least in my mind, when I'm doing a hemithyroidectomy alone, and I make every effort to preserve those parathyroid glands, it's not like I say, oh, well, it doesn't matter, there's two on the other side, so I can take these two out intentionally, right? I mean, a lot of times these patients end up needing additional surgery in the future, whether for a goiter or because they have cancer or whatever else it is. So, they talk about it as I was taught, as I'm sure you both were taught, preserve or try and preserve every parathyroid gland as best as you can. There's actually kind of a little bit of a debate in the literature about kind of finding parathyroid glands or not. Like in thyroid surgery, I'm talking about is, should you be actively looking for them or not? And what I talk about with my residents is I don't go out of my way just to find a parathyroid gland, right? So if in the context of thyroid surgery, I come across a gland, well, that's great. And this may be somewhat controversial. You may have people who are listening who are like, well, this guy's an idiot. Of course you find every parathyroid gland thyroid surgery. I don't. This is a little bit, at least in my mind, this is different than, say, the way we manage the recurrent laryngeal nerve during thyroid surgery, right? I think the standard, certainly the accepted gold standard, is you find the nerve and then you do the surgery relative to that. There are times at the end of a case where I found 2 parathyroid glands. I don't then go and actively look in the surgical field just to say, oh, I found another gland, because at that point you're only potentially, I guess, going to hurt it. Now, what I do at the end of, say, when I do a total thyroidectomy or a hemithyroidectomy, is I look at that specimen on the back table, right? Because it's not unusual if you haven't found a gland, that it's in the specimen. So I think that that's an important point. Now, and at some point we'll probably get to this, there are these new technologies that help facilitate and identify parathyroid glands. And so ultimately the idea as it relates to thyroid surgery with them is if they kind of can show you those glands earlier in the dissection, right? It's not so much just that you're then going to be more likely to preserve them, but you're also, this is the critical point, I think, is you're more likely to going to be able to preserve their vascular supply, right? If you recognize where they are on the gland, you're going to be more likely to be able to say, oh, that vascular supply is coming from above or below or so on and so forth, right? So I think everyone is taught nowadays, historically this was not the case, and that was one of the reasons why there were very high rates of hypoparathyroidism after these surgeries is you do what's called a capsular dissection. You essentially stay right on the thyroid gland, and by doing that, you're going to be dropping down these glands. But even when you do that, depending on where you make your cuts and everything else, you have quote unquote preserved the parathyroid gland in the neck, but it's not vascularized still. And so, just like everything else, the more we understand the anatomy earlier in the case, the more likely you are going to be to preserve those glands. I don't always, it's not like I start the case and I consider it a failure if I get to the end and I haven't found all 4 of the glands, but I am very actively looking for those glands as I'm doing the surgery, and particularly in certain parts, right? Like when I'm doing superior pole, when I'm doing inferior pole, I'm very actively looking for it. Now, the other thing I would say is there are definitely cases also where I am more, I'd say, proactive in terms of looking for those glands. So say, for example, if I have a patient who has really bad Hashimoto's thyroiditis, I know that that patient is probably going to be at higher risk of hypoparathyroidism. It's more likely that those parathyroid glands are going to be stuck in places that I'm not going to ever see them. Maybe a patient with Graves' disease, the same kind of thing, where I'm more actively kind of looking and saying, hey, I better try and find these glands. So, right, it's case to case, there is definitely some degree of variation.
And can we kind of just move towards talking about how you're confirming or identifying parathyroids during surgery?
Yeah. So I think one thing, and this just goes back to Gopi's comment, because, as surgeons, and I'm sure you both have seen this throughout your careers, we tend to not be as fully forthright with ourselves. I'm not talking about with our patients, about how good or not we are at something. We're just not, right? So say, for example, and I think this is why the hypoparathyroidism stuff is becoming, I think, more and more in vogue, at least in the research world, is, people talk about hypoparathyroidism and they kind of minimize it. Like, oh, it doesn't happen a lot. And even if it does, you just take some calcium pills and you're going to be totally fine. It's not a big deal. That is just absolutely not true. First of all, in terms of the impact, there is very clear evidence, not so much about transient. Transient is much less of an issue. Yeah, to me, transient is an annoyance and it can become dangerous, right? Like if you don't optimize the care of the patient, those patients, this goes back to the idea of symptomatic, right? You have a patient who is acutely hypocalcemic. They're actually at risk literally that moment. But what we know is in these patients who have permanent disease, permanent hypoparathyroidism, it can play an extraordinarily destructive role in their lives, both their kind of medical lives. From a purely medical perspective, it's really not good. the supplementation, right? So these are patients who are now, you have them on calcium supplementation, vitamin D supplementation. They're even relatively eucalcemic. And the supplementation itself over the long term becomes a health issue, right? So just every part of your body becomes essentially exposed to the potential for calcification. So that's not great. But the other thing we know is that it has major impacts on the quality of life in these patients. And so over the last number of years, as we've started to pay more and more attention to patients and their needs, I think people have started to become aware of like how problematic hypoparathyroidism is, again, when it's permanent for these patients. So that's one. The other side of it is this idea that it's not common. That's just not true. So when we look at case series that come out, particularly say in the United States or from the international arena, first of all, those studies usually are coming out from large academic centers, right? And this is true across the field in research. This is one of the problems we have is, so you're getting reporting from the top of the line surgeons. And so when they say they only have a hypoparathyroidism rate of less than 1%, that very well may be true, but that has nothing to do with what yours is. And so one of the things we've started to see, and this is not true, unfortunately, in the United States, but internationally, this is true from Scandinavian countries. This is true from some of the European countries, say, for example, Spain. When you look at large registry studies in those areas, the rate of hypoparathyroidism is dramatically higher. There was a study from Spain from a couple of years ago that reports, and this is not from some little outback hospitals. These are from large hospitals. And when they looked across the board, the rate of permanent hypoparathyroidism was 15%. Permanent. So I think that we tend to underestimate how much of an impact this has on patients, how frequent a problem it is. I think that's just an important point generally to understand, like, why is this nutty guy talking about finding parathyroid glands? And no one has this problem and it's not a big deal. And the answer is no, it is a big deal, and it happens much more frequently than we think. In terms of identification of parathyroid glands, right? And so both of you have done these cases. Sometimes parathyroid glands, and I'm now talking about thyroid surgery, they're easy. You see them, they're easy, they're obvious, either because of color, because of their vascular supply, because of, I know this one always sounds weird to people, but like because of the way they move, right? They move separately from the thyroid gland. So they'll be in the same fascial plane as thyroid, but then you push on that area and they tend to move separately, right? So there are all of these things that have historically been accessible to surgeons. Now, what those require, though, just like everything else in surgery, is experience, right? So not everyone's ability to recognize subtle parathyroid glands is the same. They're not. And one of the things that we know, and this is particularly true when you look at studies from the past, is surgeons are really not good at finding parathyroid glands. We're not.
Look like fat. It looks like fat. It looks like a lymph node. Maybe
correct.
I buzzed something. I mean,
correct.
Yeah.
Right.
And this is from the untrained. I mean, I don't do the surgery, but I'll tell you, that's what I remember thinking.
Well, and also, right, like I do a fair bit of reoperative parathyroid surgery. And what you see, like when you look at the pathology reports is, you'll see 6, 8 frozen sections. Right inferior parathyroid gland, right inferior parathyroid gland, right inferior parathyroid gland, fat, lymph node, thyroid, right? Like that's just the way it, by the way, and again, I'm wrong some of the time, and I do a lot of this, and I'm pretty good at it, and there are things that I think are a parathyroid gland, and they're just not. By the way, this goes back to what I said about this earlier. It's okay to say that this is hard. Like that, it is hard, so that's fine. So what people have tried to figure out over the years is ways of identifying these glands. And so people have tried injection of different agents, for example, like methylene blue, or they tried injection of like nanoparticles and all these other things. And ultimately, the reason that's being done is because finding these glands, again, now we could be talking about in either thyroid or parathyroid surgery, can be very challenging. So this new technology that came out now probably was first initially described about maybe 8 years ago at this point, is based off of the idea of fluorescence imaging. Some, maybe all of your listeners will be familiar with the idea of fluorescence imaging as it relates to the most common agent that's used in it, it's what's called ICG, or indocyanine green. So what happens with fluorescence imaging is you inject, say, an agent like indocyanine green, that flows to the tissue. And then in fluorescence imaging, what happens is you have a camera. The camera is stimulating that agent at a certain wavelength of light, and that then gives off a different wavelength of light, which can be, say, picked up by a camera. So ICG, and again, some of your listeners are probably familiar with this, ICG is pretty commonly used now in surgical fields, whether in plastic surgery, colorectal surgery. Any of your listeners who do, say, free flaps will probably be familiar with this. And that's used for looking at vascularity of tissue, okay? And this is where the parathyroid thing just kind of comes out of left field. Researchers, and this is an incredible story. It was found initially by a resident at Vanderbilt University, a general surgery resident. And what they figured out is that the parathyroid glands, when you don't inject anything, okay, so no ICG, no contrast agent, nothing else, that if you look at it and stimulate that tissue with the right wavelength, and you have a receiver, a camera or a probe with the right wavelength set up, that the parathyroid glands autofluoresce to a much higher degree than any other tissue in the neck. So if you point a camera at them, again, this is without any injection, you point a camera at them with the right wavelength of light, and you have the right receiver on it, the parathyroid glands light up much more brightly than any of the surrounding tissues. So it doesn't matter. Now there are devices, they're FDA-approved devices, both that are probe-based, some of them are camera-based, that allow you to use, again, autofluorescence. So no injection. You basically point this at the field, you touch something with the probe, and very readily and in a pretty sensitive and specific manner, it can differentiate, or those can differentiate, parathyroid tissue from thyroid, fat, thymus, lymph nodes, basically everything else in the neck. So, this is a little bit, and for anyone who does thyroid and parathyroid surgery, at least in 2024, probably most, if not all of your listeners use nerve monitoring. A little bit, this is similar to the idea of intraoperative nerve monitoring, right? So historically, what did we have? Well, you could look at it and you could be like, oh, that, it's pearly white, the nerve has a racing stripe on it with the blood, right? Like all of those things that we still use. And then we're able to use the nerve monitor, one, just to tell us if the nerve's functioning, but a lot of people are using it to help them confirm, is that a parathyroid, is that nerve or not, right? And this is the same kind of thing. This is not, and I tell this to people, and this is true for, I think, technologies in all these areas, this is not replacement for surgical experience, surgical knowledge. It's just not. But what these are they give you additional pieces of information to then include in your surgical algorithm in your own brain of so is this a parathyroid gland and is it not? And depending on which device you use and how you use it, it can be used, say, more effectively maybe for you in thyroid surgery. Maybe it's more effective for you in parathyroid surgery. But again, it's an adjunct tool to help you kind of differentiate parathyroid tissue from not. So
is the autofluorescence could that be the first pass device, where I'm doing the surgery and I think that looks more like parathyroid gland. I think what's next to it is fat. I kind of clean it off. We're still in the body. We haven't taken anything out. It's, let's say, for thyroid surgery. I can just see, does it autofluorescence? And that's my first pass tool, or, do I need both tools? How does...
Right. Great question. Because and this is where we go now. We'll talk a little bit about thyroid surgery versus parathyroid surgery. And this is also, it's an interesting thing. This is where you get into differences between, say, the way we do things in the United States versus the way things are done internationally, because the way these tools are being used in the United States is very different than the way they're being used, particularly in parts of Europe, some parts of Asia. So let's first talk just about thyroid surgery. So in thyroid surgery, there's different parts of it. One, like you suggested, is how am I going to find that parathyroid gland? Is this a parathyroid gland? Is it fat? Is it a lymph node? Is it thymus? And so the surgeons who have really kind of developed this into a routine, right? Where this isn't just kind of randomly using it one day off the shelf, but where they're using this on a consistent basis now as a tool within thyroid surgery. The way they start is with autofluorescence. Hey, is that a parathyroid gland? Is it not? But also going back a little bit to what I said before about helping them to find it earlier in the surgery. Okay, so finding it earlier in the surgery allows them to just kind of manage that gland better. Okay, now at this point, you have some divergence in the way people do it. Some people could then continue with the surgery as they have been, and then only at the end of the case do they add that second pass, as you're suggesting, where they then use ICG. So now we're talking about, this is where it starts to get a little bit confusing. This is no really longer autofluorescence, but actually fluorescence with ICG, and used essentially in the traditional way of using the ICG to tell you about the vasculature or the vascular intactness, essentially, of that parathyroid gland. And if the gland doesn't, say, light up, what does that mean? Does it mean it's really been compromised? Is it that it's just positioned in a way where, say, maybe, for example, the vasculature has been turned on itself, right, in an uncomfortable position? And then it allows you, and this is where research really still is not clear, is, so what does that mean? Should I explant this gland and reimplant it? I mean, I think that one of the important things to keep in mind, and this is probably true for technology across the board, at least the way I think about technology, is it can't just be a nice tool. It has to change what we're going to do. So the ultimate question is, if you use that ICG, again, in the context of like fluorescence imaging of that parathyroid gland, and it doesn't light up, does it change what you're going to do? Or does it mean, oh my goodness, this gland is no longer vascularly intact, and therefore I'm going to reimplant it or not? Okay. So some people use it, autofluorescence to help them find the glands, and then fluorescence essentially at the end to make determinations about how intact they think the vascular supply is. But the more even, and I would say most sophisticated users of this technology, they use autofluorescence, helps them find the gland. Okay. Now, before they do additional dissection, they then inject ICG, because what that does for them is, and people use different terms, they talk about angiography, parathyroid angiography, but essentially what they're using is for the ICG to show them where the vascular supply is to those parathyroid glands. And they then change their surgical approach based off of understanding, oh, the vascular supply is coming from below or from the side or from above, which is, I mean, when you think about it, is an incredibly advanced way of dealing with parathyroid glands. Now, those users, these are people who I think are really at kind of the most cutting edge. And I would also argue the most invested in this technology. But what I will say for them is they have incredible results. Because one of the things that we've learned from this, and again, this is where, you can learn from things even if you don't use it, is that our understanding of parathyroid vascular supply in the context of thyroid surgery is extremely rudimentary. And as these people have been doing these angiography studies, or what they call angiography, what we've started to really learn is to understand how complex and varied parathyroid blood supply is. And so I think even for those people who are saying, I'm never injecting, ICG to look at parathyroid gland blood supply, there's a lot of data that's coming out about where the blood supply tends to be from these studies that can be used even if you're never going to use that technology. Okay. So again, in Europe, people are kind of doing, like you're suggesting, a combination where they're using the autofluorescence to help them find the gland, and then they're using ICG to, say, for example, identify the blood supply, and then at the end determine whether they think that gland is intact from a vascular perspective or not. That is not nearly as widely being performed in the United States, that combination. American surgeons, I think, for a whole bunch of reasons, we're, I'd say, more cautious in terms of using some of these technologies. I think some of it goes back to what I said before about, I think we as a group tend to be somewhat dismissive of how common a problem hypoparathyroidism is. And so to date, people haven't been as willing to, say, invest as much effort in trying to prevent it as maybe we should. But in the United States, people are using more of the autofluorescence aspect of it within thyroid surgery. Okay, so that was a very long-winded answer to your to your relatively short question.
I have never used one of these devices. And so just to kind of paint the picture, when you're using maybe a probe, is it a probe to kind of for the autofluorescence part of it where you're kind of going to touch it? Just like I liked your comparison with like nerve monitoring, because that's something that most people are probably very familiar with. So you touch it and it gives you some sort of audible, ding, 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 that is parathyroid, or how does that part work?
And I'll say this because I like to be very upfront. So there are different technologies. One of them is probe-based. It's actually produced by Medtronic, and I say that on purpose because I am a consultant for Medtronic, so I just want to disclose that. I don't really care about which technology you use. I'm interested in people using, or at least trying, one form of these technologies. There are two versions that are available. So one is this probe-based system it's exactly as you described, very similar to nerve monitoring, where you touch it. There's some additional details in terms of the background of how exactly you get these numbers. But essentially, if you get a certain response, the likelihood that that's a parathyroid gland is very high. And it's both visual and audible, okay? There are advantages and disadvantages to that. Certainly for people, say, for example, who use nerve monitoring, it just feels very intuitively similar, right? The disadvantage is you really need to have some sense of what a parathyroid gland looks like to trial it, because otherwise you essentially have to paint, just like using the nerve monitor, right? You need to have some idea where the nerve is. Otherwise, like, you're going to literally just walk around, painting the whole field. The advantage of the camera-based systems, I think, is it is more helpful for having this kind of global view, right? And so theoretically, in thyroid surgery or parathyroid surgery, I guess for that matter, what's nice to some degree with the camera systems, at least in theory, is that you open up the field, and now I take out this camera and I look at the field, and that's projected then onto a monitor in the operating room. And theoretically, if you see a parathyroid gland, or if the camera sees it and has enough of a response, you're going to see these kind of bright spots on the screen, right? So it gives you a much more global view. So there are different options. And to me, again, it's not about one versus the other. They each have advantages, disadvantages. I don't think that's really the point of like our conversation right now. I'm happy to talk about it. To me, it's just more about being familiar with this technology that's out there and trialing some. And what I say to people with this is, I think what's important is that people just kind of acknowledge to themselves, what is the challenge that they encounter with parathyroid glands? I have no idea what one looks like. And so I need something that can look at the field and say, hey, there's something over there and there's something over there. Or is it that they're pretty good at it, but they still get it wrong a fair bit of the time, and they need something that they essentially can use almost like a rapid frozen section, right? Those are different challenges. Or, for example, maybe their challenge is, hey, I can find that parathyroid gland, but I have no idea how to keep the vascular supply intact, right? And so this is where you, I think, as an individual surgeon, have to say to yourself, what challenge do I have? Like, just be honest. You don't have to say that out loud. You don't say that to the rep, right? You don't necessarily say that to the patient, but just for myself, like, what is it? And it's okay if the answer is, I have no idea what a parathyroid gland looks like, but then let's use something to help you, right? And the same thing with the vascular supply and so on and so forth. What I will say that's interesting is that these technologies really were developed, and there's a number of reasons why, with the initial idea of using them to help find parathyroid glands, to help assess vascular supply in the context of thyroid surgery. But then once these companies came out with it and they actually started introducing it to surgeons, guess what surgeons said? Wait, you have a device that can help you find parathyroid glands. Why are you talking to me about thyroid surgery? Like, it's so funny. Like, you see the companies or you start talking to them about it and they're like, okay, but why are you talking about thyroid surgery? What's the obvious potential utility of a device that helps you find parathyroid glands? parathyroid surgery, right? Because, I think everyone who's done any number of parathyroid cases knows those amazingly challenging and frustrating cases where you're looking, and you can't find the gland. And so that idea of finding parathyroids in parathyroid surgery, I think we're all familiar about it. By the way, this goes back to you. Even if you are doing them in practice now, right? Just from residency, where you're like, oh my God, I was in that case for 4 hours with doctor or whatever else. He or she was getting so frustrated. I am never doing one of those cases ever again.
We're using the probe, we're sending labs, we're sending frozen.
Oh my God. Like this is so, and like the surgeon then starts to get all like anxious
and then we start
worked
looking at the different abnormal possible placements.
Right. And then, you're looking in the carotid sheath and the chances at that point you're going to find
behind the esophagus.
Right,
like, where are we?
Right.
Yeah.
And so as soon as these things came out, people started saying, well, why aren't we talking about this in the context of parathyroid surgery? And this goes back to my comment before about what I said about what's the utility. I think that one of the challenges with this is the data so far has not necessarily been super convincing that everyone should be using it in every single parathyroid case. But I would argue there's different reasons why I think that is. And a big part of the reason is because if you're doing research at a large institution and you do a lot of this, right, the number of times where you really can't find a bad gland, it's really quite limited. And so to see a change, you're going to have to do thousands and thousands and thousands of these cases with this technology. But what I do know is what I think is fascinating is when you talk to people who do a lot of this, and I don't care who you are, ENT, surgical oncology, endocrine surgeons, general surgeons. So I'm talking about people who do the highest volume, say, in the United States. What they will all tell you is that at least in some of these cases, this technology has helped them. It just does. It makes a difference. Now, the precise way it helps them varies maybe from case to case. I think there are very few people at this point who would say, hey, you've got this parathyroid gland where it's lighting up like a light bulb on a sestamibi scan, and the ultrasound shows exactly that same area. The people who do a lot of this, and I think even the people who do less of this, I'm not sure that the technology is going to be helpful in that case. But in some cases, foregland explorations, non-localizing cases, I think the technology could be really potentially make a significant difference. The other thing, and this is actually my area of research interest at this time, is not so much just, can this show us a parathyroid gland or not, but potentially, and I think there is the potential that's there, that this can tell you whether something is pathologic or not. So, this is one of the other challenges in parathyroid surgery that isn't discussed very much, but especially if you start to do a large volume, but more subtle parathyroid disease cases, there are cases where it is very difficult to differentiate something that's normal from abnormal, right? So if you go in there and you find a parathyroid gland that's the size of a walnut, well, I think most people are like, okay, that's not normal. But there are cases where you find all four of the glands, and yes, one of them is abnormal. This is not four-gland hyperplasia. This is single-gland disease. But it's not immediately obvious, is it pathologic or not? And to me, these technologies potentially can be used not simply to say, hey, yeah, that's a parathyroid gland, it's not a piece of fat or thymus, but they can say, yes, that's normal. That's a normal parathyroid gland. That's a normal parathyroid gland. Whoa, that one's not. And so theoretically, if you have a device that tells you that, I think it could make a big difference. I think it brings back into question the whole way we're doing these surgeries, right? Like, are we doing focused surgeries? Are we doing non-focused surgeries? Do you need to use intraoperative PTH and sit there and wait 35 minutes, right? If I've gone and I have a tool that tells me objectively, I've found 4 parathyroid glands, and objectively, not just with my eyes, yes, that's normal, that's normal, that's normal, that's pathologic, I take out the pathologic gland and we're done. I'm not sitting there and waiting those 35 minutes or whatever it is at your institution, right? And so I think that the technologies potentially can be used now in the way that they're available, right? They can be helpful in thyroid surgery. I think they can be helpful in parathyroid surgery now, at least some of the time. But I also think just like everything else, right? Like I tell people, it's like the first iPhone. If you look at that first iPhone, you're like, wow, this thing stinks, right? But when it came out, it was like earth shattering. And now the current iPhones are on it just a totally different level. And it's the same thing with this. I have a feeling that this, as it evolves, we're just beginning kind of to scratch the surface of what these technologies kind of can do in these cases.
So, Michael, can we quickly kind of talk about the Medtronic probe, the PTeye? Is that a fluorescence or an autofluorescence technology?
Yeah, so I don't want to confuse people because it's once you start talking about, it's like talking to patients about thyroid versus parathyroid. You know, they have the same word in them. So patients are like, wait, thyroid, parathyroid, right? So it's the same thing here. The device, all of these devices are really, they're designed for fluorescence. It happens to be that parathyroid glands have this quality, this intrinsic, what's called a fluorophore. There's something in there that almost acts like you've injected ICG into the gland, right? But what's important is that currently, this is very important, the device is FDA approved for autofluorescence to help confirm something to be a parathyroid gland or not. That's what it's for. And I think, and this is where some technologies really just do it. Like this thing was brought into my operating room the first time, and I'm a somewhat skeptical surgeon, right? You have people show up in your operating room all the time with devices, technologies, and they're like, oh, this thing is going to change the way everything you do. And you're like, okay, whatever. And then you use it and yeah, it turns the operating room purple and you're like, okay, so what? How does that help? This is like one of the first devices or one of the only devices that I've ever used where I used it and I was like, wow, this thing does what it's supposed to do and really does it pretty accurately without any, it's not complex. Maybe, I have a comfort level like Ashley was saying, because I use nerve monitoring, maybe it was just very kind of intuitive, its use. It really kind of does what it's supposed to do. And what I say to people is a little bit, this is like when nerve monitoring first came out, and one of the issues they had with getting surgeons to adopt it is surgeons would stimulate something, say with the nerve probe, that wasn't the nerve, and they would say, oh, this technology stinks. Right? They'd say, oh, this technology doesn't work. That's the nerve and it's not stimulating. And guess what? It wasn't the nerve, right? It's the same thing here, right? You have to be open to the possibility that as much as you do, and like I'm talking about for myself, like as much as I do, there are times where I'm wrong. And so I'm like, oh yeah, that and I have residents, so I'm forced to be pretty honest because otherwise nowadays they'll call me out. Historically, you would have just sat there and afterwards gone over to your resident and co-resident been like, this guy doesn't know what he's doing. But, there's times where you stimulate something and you think it's a parathyroid gland and it's just not, right? But you have to kind of trust the technology to some extent, right? Because the technology is not perfect either. It has false negatives, false positive, those kind of things. So and I've used the camera-based system as well, and there's different versions of it. I think that the camera-based system has advantages too. The camera-based system, one advantage of it, at least in its current formulation, is that it allows you to look at both fluorescence, and if you're interested in looking at vascularity, it allows you to do fluorescence imaging also. I think the other big advantage of it is it gives you a global view, right? This isn't like, oh, I'm testing this one micro area. It's assessing the whole area. And so if you have listeners who are actually interested in trying these technologies, I would encourage them to try both and see what they feel more comfortable with and what works in their hands. A little bit, this is what I was saying before about just everyone has to know what their challenge is. For anyone to say, oh, no, the one that you should use is this. everyone has different challenges. And so you have to figure out which of these devices, if you find them helpful at all, maybe you won't find them helpful at all, but which of these devices potentially helps you address the challenges you as the individual surgeon really are trying to deal with.
Would you say that it has changed the way you do thyroid and parathyroid surgery? If so, how?
I would say the two areas that it's had the biggest impact, and maybe this is not surprising, at this point, my practice has largely, not exclusively, but has largely become parathyroid surgery. I think that the areas that it's had the biggest impact is probably in parathyroid surgery, okay? There are definitely instances where in thyroid surgery, I find it's already made differences for me. Say, for example, in reoperative central neck dissections, where there's a ton of scar tissue, parathyroid glands are genuinely at risk in those cases. I think that in those cases, it's already been helpful to me in certain instances. But where I could tell you it's made probably the single biggest difference is in parathyroid surgery. It has eliminated in my practice the need for getting frozen sections. Now, the reality is that I don't get very many frozen sections to begin with. Some people use frozen sections on a routine basis. Some people use them only in challenging cases, all these other things. But even though I don't always get them, I still do occasionally get frozen sections. And the way I use this technology now, it's eliminated that. I don't want to say 100%. You're right. There is nothing that we use that's 100% of the time, 100% accurate. It's eliminated that need. And one of the things that does, particularly in more challenging cases, maybe cases of bilateral neck exploration, is it's almost an automatic and immediate, that's the key, frozen section, right? So one of the annoying things with frozen sections is, if you could get that result instantly, it helps you. But when it takes 25 minutes to get the result back, because it's not almost real time, it doesn't allow you to make surgical decisions as readily. You're like, oh, okay, now I'm going to wait for that biopsy result. I'm going to go and do something else, and then I'm going to come back to this question that I have, right? Whereas with this, it's kind of like the nerve monitor in the sense that it immediately tells you. So then you can say, okay, I now know I've found this gland, so let me move to the next gland, or now I've found all 4 glands, or however else it is. And that, I think, allows me to make certain surgical decisions and then moves much more quickly than I would have in the past.
So, Michael, for your parathyroid surgery, are you still sending PTH levels to have more of a functional tests in conjunction with the autofluorescence technology, or are you not doing that as much now either?
I'm not so dogmatic about the way parathyroid surgery is done. So what I mean is some people, they only believe in this approach and they do this on every single case. I'm not as much as that. So say, for example, if I found all 4 glands and I look at one of the glands with my eyes and I'm like, that's clearly normal or that's clearly abnormal. And the rest of these glands that I've found and I know that they're there, either on my own or because I'm using one of these devices to confirm that stuff is parathyroid, I don't get PTH levels in that case because I know. Now, as we all know as surgeons, sometimes we say, 100%. And guess what? 100%, you're not. That's not 100%, right? It's just not. I mean, this is where you need to be at least a little bit, try to be humble as a surgeon. Some of us are better at that than others. It's not that it's like, I now use this and that's eliminated PTH levels. That's not the case. But in those cases where maybe in the past I would have used it because I'm pretty sure the patient's cured, but I'm not 100% sure that other thing that I found was a parathyroid gland, that then there are cases where it's just like, okay, I'm not going to wait now. But for example, these technologies right now, if you're doing focused parathyroid surgery, you are still obligated, at least in my mind, and I know there's some people who don't, but at least in my mind, you're really obligated to use intraoperative PTH to verify that in fact the remaining glands are not hyperfunctional. And at this point, that hasn't changed. And I think if it ever is going to change, we're going to again have to go back to that question of so should we be doing bilateral neck explorations on all patients? Should we be looking at all parathyroid glands?
Yeah. And as far as, I think to your point about kind of time saved when you're comparing waiting for a frozen versus being able to have that instant verification that it is parathyroid, when you start talking about cost and the added cost, time in the OR is one of the most expensive items when you think about surgery. And so do you feel, I assume that you feel like that being able to buy back that time makes up for the cost of adding the device to the surgery?
Yeah, I mean, I think that, so the first thing I would say is that I am not an economist. I'm not an economist. I actually do pay attention to cost, even though I literally have never had, say, someone from my institution come to me and say, oh, well, like, why are you using this? Or do you really need to? It doesn't happen in the practice I have. It doesn't happen that much, but I do pay attention to it. And I know that that's a real genuine issue. I, as a kind of academic surgeon, I feel like my job is to try and help figure out, is this technology helpful? How can it be used? Really, where are the benefits? Because to me, that's related to cost, right? I don't know that there's ever going to be a time that it's going to be like, oh, this is so amazing and it's so relatively cheap that you should be using this on every single case. I don't know that that's ever going to happen. But I think that like our job as academic people is to try and help figure that stuff out. And then work both with hospital administrators, but also companies to find a point where they're still willing to make it and invest that money in developing these technologies, which we want, which are good for our patients, but that's not so expensive that it prevents us really from using it. And so I think, and this is where I think there is a lot of similarity to nerve monitoring. When nerve monitoring first came out, first of all, the first thing that happened was people said, we don't have nerve injuries. They just don't happen. Okay. Well, pretty quickly, and this is really largely due to the effort of a few people, particularly Greg Randolph from Harvard, people started to say, wait, no, nerve injuries are actually happening. And then surgeons started to say, yeah, they happen, but not in my hands, right? And then they said, well, I don't really need this. It doesn't really help. It doesn't this. And then eventually people got to the point where some people were using it in some cases, right? Oh, I'm going to use it in re-op cases. I'm going to use it in substernal cases. I'm going to use it in, cancer, whatever it is, right? And over time, that has evolved. And this goes again back to the cost question. That's evolved to a point where now many people at many institutions, many practices use nerve monitoring and wouldn't even think of doing, say, thyroid surgery without it. It's gotten to that point. Now, I don't know that this type of stuff is ever going to get to that same point where it's like being used regularly every single case. I don't know, and honestly, I don't think that's probably going to be the case. But what I do think is that as time goes by and the technology gets better and we figure out, oh, you know where it's really helpful? It's really helpful in X case and this case and that case, that it's going to become it's going to become integrated in the way we do at least some cases. Now, again, you still have people who are doing thyroid, say, surgery on a regular basis, and they say, I don't need nerve monitoring. It doesn't help me at all, right? And so I'm sure you'll have the same thing with this. You'll have people who say, I don't ever need this. Okay, that's fine. And then you'll maybe have people who say, oh, you know what? I use it on every single case because I just would never feel comfortable not using it. But I think you're going to end up getting to a point, again, where the technology is good enough. It's relatively inexpensive. And that's the key word, relatively inexpensive. It's not going to be cheap, but compared to, say, a bad outcome or a complication or all these other things, where it's going to get to a point where people are going to start to integrate this in different ways to varying degrees in their practices.
So as we start to round it out, just in the interest of time, I've learned a ton, especially about being forthright with myself as a surgeon. Any final pearls that you want to leave our audience with?
Yeah, so it's funny because I think I would just say that one of the best things that came out of my fellowship was I spent a lot of time with Dr. Terrace. One of the things that I learned from him is, and it's not that I hadn't learned this in residency. I had other faculty, of course, who kind of talked about this and I saw it. But I think that one of the things, this goes to your comment you just made, Gopi, about that he said is he really emphasized the idea of just being open to new things, right? Just being open to new things. He would talk about the idea of maybe you don't always want to be the first, but you don't always want to be the last, right? And I think that that's relevant to this technology. I think it's true to all technologies. We all know that, some things come along and they're super flashy, and a company may say this is a cure-all, right? It's the silver bullet for the problem. Sometimes I'll say for financial reasons, people run to, adopt certain things. But then you also have people who are like, I don't need that, or I don't have that problem. And so one of the things Dr. Terrace would always talk about is just be honest, at least with yourself, about how good you are at something, and can you use some help at least some of the time, and then consequently say, all right, well, how do I get better? And so this goes to our conversation from earlier about the idea of average and expert, and it doesn't matter what level you are. I tell this to my patients all the time. We all can get better. We can. And I don't care. At the point where you are saying, I'm the world's authority on this, I'm perfect, it is time to get out. Like that's when you're really going to run into trouble. And so I think the idea of just being open to things, to just continuously try to improve, both for yourself, but most importantly for our patients, I think it's applicable, again, to this technology. I think it's applicable to technologies that probably go throughout all surgical and medical fields. But that was honestly, that was one of the best parts of my fellowship, because I think it just made me think about things in a very, sometimes brutally honest way. And I think ultimately that's both good for me and for my patients.
Yeah, I love that. Continuous learning, stay humble.
Right. I mean, that, by the way, that's the point. I imagine, I don't know, but that's to some extent the point of the podcast, right? Like, why do we do this? And it's about saying, hey, you know what? I do a lot of this, but maybe there's something new that I can do, or maybe I can do this.
Or I don't do any of this, and I really had to research and look up things.
Or maybe I don't do any of this. Maybe I don't do any of this, and maybe it's
but
good
I don't do any
of it. I don't do it, right? I shouldn't do any of this. Like that's also an important realization. So yeah, I imagine that that's part of the goal of your podcast, right? Is to try and address people, or deal with people who are saying, hey, what can I maybe do better?
If people want to connect with you or reach out to you to kind of discuss more, is there a good way to get a hold of you? Are you on any socials, or just kind of find you on Henry Ford Health?
Yeah, so my kids will tell you that I'm a dinosaur because I'm not a social media exactly maven, but I'm old school, at least what's now considered old school. You can, go on our website. But the best thing is just to email me. Maybe you guys can put, I don't know if you have like show notes or whatever else. The email is msinger1@hfhs.org. That's henryfordhealthsystem.org. And I'm really happy to kind of talk about it. If you have either interests in this or questions about parathyroid glands or parathyroid surgery, as you can probably tell, I'm a little bit of a parathyroid geek. This is a topic that I could talk about for a long time, so I'm really always happy to. I told Gopi the risk is if you get me on the phone and get me going, it may be a little while, but as long as you're willing to risk a little bit of more time on this than you want to, I'm really happy to always talk to people about stuff.
Thank you so much. This is great.
Awesome. Thank you so much.
My pleasure. Thanks, guys.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable ENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.